So I'm going to be talking about systemic chemotherapeutic options for appendiceal cancer. And this is really kind of a understudied area. And we're just trying to, I remember when Dr. Lowy sent me my first appendiceal cancer patient, and there was just no data. There was one British Journal of Cancer article showing some resistance to platinum-based therapy when patients have mucinous-based tumors, and that was about all we had to go on. I mean, as you guys know, if you look at the NCCN, there's about a paragraph about appendiceal cancer. There's really no guidelines. They're all extrapolated to the colorectal CRC panel. There's limited data. I mean, there's published studies about capecitabine, FOLFOX, Avastin, but most of the data is on cytoreduction and HIPEC. 5-FU is probably the most predominantly used. I mean, even then, if you look at all comers for appendiceal and colorectal cancer, the response rates aren't great, and the survival is not very good as well. So the overall recommendation is whatever can be used for colon cancer can be used for appendiceal cancer. So we look at the colorectal treatment options. I mean, there's single agent therapy, 2-drug, 3-drug, and 4-drug combinations. A lot of it has to do with what patients are able to tolerate and what is the goal of therapy. So when we look at specific considerations for appendiceal cancer, we looked at some of the trial data, like the CALGB, which looked at Avastin benefit in right-sided tumors. When oncologists are asked what preference do they like in terms of what's their baseline chemotherapy option for colorectal cancer, the overwhelming majority is oxaliplatin-based, and that's all based on perceived efficacy. And actually, if you look closely at the data, the FOLFIRI versus FOLFOX, you'd probably go with FOLFIRI anyways. And for peritoneal-based tumors, I think that's probably a better way to go. Oxaliplatin has, I mean, this is primarily where we see patients coming to us. They've had 6 months or 10 months of FOLFOX, and they're looking for some other treatment decisions. The problem with this tumor type, it's rare. And it's difficult to conduct prospective or randomized clinical trials because of the rarity. It's tough to assess therapeutic endpoints. Imaging has always been a problem. So we look at RECIST criteria for size of the tumor. So we typically, for most clinical trials, we look for measurable disease. Sounds unfortunate, but we have to have something to follow. And it's tough when there's peritoneal-based disease and there's not a specific lesion that we can follow. The PET scan's been notoriously nonspecific and non-sensitive. There is an overall lack of dedicated pipelines for drug development in this disease entity. And other problems with the difficulties in trial design are the histological subtypes, and there's a whole bunch of different responses in terms of overall survival, even based on subtype. And even when we're looking at the molecular precision of this type of tumor, it's tough to get tissue genetic studies done because these tumors are notoriously acellular, and we get a quantity not sufficient for most of our in vitro studies. So again, we look at treatment options: FOLFOX plus Avastin, FOLFIRI plus Avastin. FOLFOXIRI has a higher response rate, but again, it's very toxic. We don't have much data, if any, on adjuvant therapy, status post cytoreduction, HIPEC. We have to incorporate the role of observation. Is there a role for immunotherapy, how to sequence therapy, and looking for clues. What is the tumor telling us to do? So Dr. J.P. Shen and Michelle Kochiri worked here with me. And we looked at in colorectal cancer, looking at the difference, what the tumors could tell us. And certain gene expression patterns favored a better survival and better response to platinum-based therapy. Patients that had high ERCC1 didn't fare as well, as you can see up in this A plot, where the red line is a high ERCC1. ERCC1 is a repair protein for platinum-based induced cellular toxicity, and if you overexpress it, you can repair these proteins, damage DNA damage induced by platinum. So it makes sense. We look at this in comparison to colorectal. I'll get to some of this later, but when we looked at some of our early studies and sequencing, we looked at appendiceal cancer. We looked at some of the DNA. What are these gene mutations that are driving these cancers? We looked at 14 samples, and we kind of see most commonly mutated gene was KRAS. P53 was mutated as well. But if you just look at this overall plot, there's not a lot of gene mutations per per tissue sample. Whereas when you look at colorectal cancer, there's a significant difference. This was our first hint at it's much more heterogeneously seen in colon cancer in terms of the average number of mutations of 3.7 versus colon. So we're looking at less pathways to inhibit theoretically in appendix cancer, but it's also clearly looking at like these are two different diseases. We started publishing this experience back in 2013. We looked at some of the signals for ERCC1, TS, and some of these other things that would suggest a response to certain types of cytotoxic chemotherapy. We really didn't find much in terms of a link with overall survival. We did see that patients with metastatic appendiceal cancer had a much significantly longer overall survival than metastatic colon cancer patients. It was a little bit disappointing. We looked at, there was another study by Borazani that looked at 442 cases, looking at all the gene expression profiling. It gave us a platform, but not a blueprint for treatment of disease. It's interesting. It's very difficult to put together a prospective trial based on biomarker expression because you have to have an enormous amount of people. This is going to be very difficult in this disease. When we published more recently last year, we looked at 703 appendiceal cancer specimens. So it becomes very clear now that there's a differential gene expression pattern between appendiceal cancer and colorectal cancer. These are definitely different tumor entities and probably shouldn't be treated the same. Just based on location, it's treated like a colorectal cancer, but this is clearly not the way to go about this. One thing about imaging, I mentioned earlier, it's important that, Dr. Russell Lowe is a published author of using MRI with diffusion-weighted imaging and dynamic contrast enhancement, which you can see here, he's picked up these areas which at the time of surgery in this 25-year-old patient, all were consistent with biopsy-proven metastatic disease. So it's as close to a PET scan, so to speak, as we can get. So this is one of the things that we need to incorporate in some of our clinical trials. Looking at other treatment options for this entity, I started looking at appendiceal cancer, and we were using Omniseq. And Omniseq's for kind of a simple way, it's like the immunotherapy report card. It gives us a review of probably about 40 or 54 different genes associated with anti-cancer immune responses and immunotherapeutic targets. It looks at things like tumor mutational burden, PD-L1 expression, a bunch of other things that have been associated with their surrogate endpoints for response to immunotherapy. So when I looked at these 14 patients, we get this signal where if you look at the far left, PD-L1, which is one marker for a response to immunotherapy, none of these tumors do not express a lot. They just don't express PD-L1. They have moderate to low infiltrates of tumor infiltrating lymphocytes. Generally, their CD3 to CD8 ratio is not favoring an immune response. These are low tumor mutational burden. There's not a lot of mutations driving these, and this typically portends a lack of response to immunotherapy. They're all microsatellite stable. Microsatellite unstable patients are the ones that generally have a response to immunotherapy. And the PD-L1 to PD-L2 copy number just isn't available. So we're running into a negative kind of response. But when they look at these other 43 genes that are responsible for looking at other immunotherapy agents we can combine with certain immunotherapies, VISTA inhibitors, the CSF1 R antagonists and TGFR beta-1 inhibitors and TIM3 inhibitors all seem to be kind of playing a role in these, at least a small subset of patients. It's important to, well, that being said, it doesn't look like there's a good immunologic landscape, but the problem with this disease is people can't stay on systemic chemotherapy forever, and we have to find a maintenance therapy for them. So immunotherapy kind of fits that role. When it works, it's beautiful, and we have to figure this sequence out. I've treated 3 patients so far. One patient, all these patients had a GNAS mutation, which I'll get to later. But one patient had 11 months, 8 months on Keytruda. Another one was 12 months on Keytruda, which is pembrolizumab, which is a PD-1 inhibitor. This gentleman, this last one, he actually had a little hepatitis associated with it, but that settled down, and now we're putting him back on it. So there is, maybe it's this GNAS mutation might have something to do with it. Maybe that's the only thing I can find in common with them, because the rest of their signature said that immunotherapy shouldn't work. Combination therapies, I should go back to this slide. There was a clinical trial at ASCO with nivolumab plus regorafenib, which showed about a 29-30% response rate in microsatellite stable colorectal cancer. So I think the paradigm would probably be, and as with most GI cancers, is pairing immunotherapy, immunologic agent with cytotoxic chemotherapy. So that's probably going to be the way it works. The drug regorafenib, it's kind of what we call a dirty tyrosine kinase inhibitor. It's not a bad thing, but it's really not specific for certain. It targets a lot of different enzymes in PDGFR alpha, c-KIT, and all these things that have a lot of toxicities, not just in tumor death, but also in giving diarrhea, just kind of loss of weight. So it's a really tough therapy. We need more focused therapy, and we need a champion in the biopharmaceutical to help us with this, with appendiceal cancer. Looking at GNAS, which I mentioned was associated with the responses to immunotherapy. This, it's an activating mutation. It's seen in the majority of patients that we see with this. It's not a targetable agent. There may be some MAP kinase and Wnt signaling inhibitors that we could try, but there's just not a good target at this point. This is something that it's also seen in colorectal cancer with KRAS. Again, it's not targetable. As far as developing future therapies for appendiceal cancer, we know that it tends to hone into the peritoneum, so we should take advantage of that with clinical trials of intraperitoneal agents, enzymatic targets. There's a lot we need to do as far as VEGF signaling regimens, because these are almost invariably mutated with P53, which in retrospective studies have shown a response to Avastin-based therapy. Problem with Avastin in this disorder is potential for fistula formation and wound healing, and it can be a problematic drug in terms of hypertension, stroke risk, and what have you. Moving forward, we need to talk with the surgeons and accelerate the communication. I think this is a rare disease, and I think a lot of medical oncologists have a lot of apprehension when they see these patients. They don't know what to do, and invariably they get FOLFOX. And by the time we see them, they already have neuropathy and are subsequently progressed on that base therapy. We need more clinical trials. We need to aggressively focus on the maintenance of ball function. Palliative care intervention is always a significant portion of this treatment in this disease. We need better intraperitoneal agents, and we need better ways to administer patients when they have terminal bowel obstruction for G-tubes, and certain ways we can help people maintain the ability to eat, which is one of the most human things we do. There are some clinical trials with, this is about all there is in clinicaltrials.gov. There's not a lot of directed therapy for appendiceal cancer. One of the studies is iPredict, which we recently published our data here in Nature, looking at the benefit of targeted therapies and basing treatments decision based on their tumor expression profiling rather than just where the tumor arises from. So it's, we have a long ways to go. I think we're kind of trying to get there. We need to, again, we need some support from people like you to speak to pharmaceutical companies, and why aren't they actively engaging? I think it's rarity. I mentioned the difficulties in trial design, but we really need some additional agents based on some of the molecular studies that we've done so far. It's a challenging disease. We've seen patients triumph over it. There's a lot of people in here that have told me some stories out here. So there are people that survive, and we need to better understand the sequence of therapy as well. But that's all I have for you today.